Calling all EMTs and paramedics, we're talking stroke, time is brain, and we've got to act fast. So if you're looking to tune up your stroke assessment, treatment, and documentation practice, you have come to the right place. Hello, everyone. Hope you're having a great day. He's Paul Gerard. I'm Kevin Kelly with Gerard & Associates. Check out a treasure trove of information on our website, www.gerardassociates.com. This is the G&A Way EMS CQI podcast. Thanks for tuning in. Check us out on all of the podcast players. Paul, it's great to be with you on another great topic. Let's talk stroke.
All right, let's talk stroke. What would you like to talk about with stroke?
Well, set it up for me. 20 years, 400,000 coaching sessions, run report audits, stroke. It's one of those treatment modalities that paramedics need to nail. We got to do a better job at assessing, and we definitely have to do a better job at documentation. So what are the issues out of the starting gate? What are you seeing? What are the auditors seeing?
All right, so yeah, that's a good place to go. So we see a variety of things, and with any one of these clinical topics, Kevin, you and I were talking about this prior to getting on air, is that there's lots of different things in the CQI process that you can find and you have to deal with as a CQI coordinator.
Right.
But when we talk about these topics, we're really looking at the top, 3 or 4 or 5 issues that we see commonly. What are the common issues that we see people making mistakes with? Because if you fix those, a lot of secondary issues can go away. So we're not, trying to give a laundry list of the 45 reasons that, people miss stroke stuff. But so the top one, probably the biggest one that we see most oftenly is, why didn't the providers do a stroke exam on this particular patient? That's the comment that gets brought up by the auditors most frequently. And the issue is that providers sometimes don't consider stroke as a differential for some of their patient types. So you get a little lady who's got, a good example is a 79-year-old guy that we just did not long ago, a couple of weeks ago, who was having visual disturbances, and that was it. That was his only complaint. So just having some visual things didn't look right out of his, the corner of his eye kind of thing. Mm-hmm. And so the providers, just said, well, he's got an eye issue going on here. Let's throw him in the truck and BLS him to the hospital. And he turned out to have a stroke. So they didn't consider that visual disturbances can be a sign of stroke. What most providers have gotten accustomed to seeing is that patient with the facial droop, left-sided weakness, dragging their foot, can't ambulate well, those types of things, the obvious stroke patients.
Right.
But they miss oftentimes the unobvious stroke patients. So we've seen a number of patients who are having, septic, for example, and have an altered mental status. And the providers say, well, they've got an infection source and blah, blah, blah. I'm going to go with sepsis. And that's not unreasonable, but they didn't do a stroke exam. And when you do the follow-up stroke exam, you find that they're also having a stroke. So I'd say probably the number one issue is just missed opportunities to identify strokes because we're not running enough people through the stroke exam protocol.
Now, based on the interviews and the coaching sessions,
yeah,
what are typically the reasons that we get to that differential diagnosis fork in the road and we choose the stroke less, the non-stroke less traveled?
Yeah, right. Anchoring bias oftentimes, and just having blinder's eye, right? The patient says to you, I'm having whatever I'm having, but I get this when I get my migraine headaches. This is what it feels like when I get my migraine headache. So they don't consider that headache in an elderly patient could potentially be a stroke sign, right? And so they oftentimes will just listen to what the patient tells them they think it is and go with that. So I've got a history of hypertension. My blood pressure's high. It makes me feel funny. I just don't feel right. And they're very vague with what they don't feel right with. And the provider takes a pressure and it's 190 over 110, 120 or something like that. And they go, oh yeah, your pressure's too high. Let's get you to the hospital, get that treated. And they don't think, well, potentially they could also be having a stroke either because of the high blood pressure or in spite of the high blood pressure. It could be a separate thing going on with the patient. So they may be connected, they may not be connected, and they don't have that investigative instinct to go after more than just the obvious. So that's a common theme.
Now, we talked about on the last show going through school. How do you
Yeah.
get through your paramedic program
Yeah.
and be 100% competent at that differential diagnosis, connecting the dots, creating that nexus, being that detective? Things don't, putting the evidence together. I got a visual disturbance and I got a blood pressure of 200 over 100. Maybe
Yep.
I should do a neuro exam to determine
Right.
whether or not we got a neuro deficit.
Yeah.
Why do we perform with such great proficiency in school and come out with this seeming simple
Yeah.
symptomology and,
Right.
and botch it
Right.
up?
Right. And I think we discussed this in previous episodes where in school, you know, you're doing this week, we're doing the stroke module. We just had all the stroke lectures. So all my answers are going to be stroke. You kind of, you know,
Right. Yeah.
what's wrong with this patient? Stroke? You're right. So, wow, you're great. Here,
Yeah.
100, you pass.
Yeah.
And I think so. I think that they're conditioned a little bit in the classroom process. They have a little bit of a cheat sheet going, right, where they kind of have they suspect what might be going on based on that sort of. So I think some of it is just that in the education process, it kind of led that way. The other is in the education process, they oftentimes use standardized presentations, and they'll talk about the outliers a little bit. You know, you be careful for these other patients. So I think it gets presented in most cases, but whenever they are giving you a test or an exam or a practical or whatnot, it's always, okay, this guy's feeling funny. He's got a headache. He's got a facial droop. Ding, 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 ding. You know, you kind of like,
Right, yeah.
So I think that's easy in class. When you get out in the field and you see the patients having crushing chest pain and they're pale and diaphoretic and they've got ST elevations throughout and you go, oh, I'm dealing with a STEMI. But the patient also seems to be leaning to the left a little. We sometimes don't connect those dots because that's not really how it wasn't emphasized, I should say, as much as perhaps it should be in the school setting or in the exam setting. So that patient could have a multitude of medical conditions and histories, and that little bit of listing to the left problem could be from a variety of different things that patient has on their medical history. So again, you know, oftentimes the schools, they try not to complicate it too much by giving you a patient who's 97 years old, has 15 different diagnoses, each of which could explain the symptoms the patient's having today, or they could be having a new onset stroke, which is not one of their 15 previous diagnoses. So it's more complicated in the real world, I think, and it's incumbent upon our field supervisors, our trainers, our CQI folks, and all those people involved in the everyday administration of EMS care to help providers when they come out of school to understand that in a real world context.
So common theme throughout our podcast is be a detective and don't go for the head fake.
The head fake, right.
You don't go for the head fake. What else, Paul?
Yep. So another is we often see that people will misdocument and maybe even not get proper information regarding patient last known well time and onset of symptom times. A lot of providers confuse the two and think they're basically the same. They're not. They're representative of two separate points in the patient's evolution in that potential stroke, and they need to identify the times for both of those categories. And within that topic, people will oftentimes document last known well time or last seen well time, and they'll document it inappropriately by saying, patient last known well time was patient went to bed last night with no symptoms or something. And so they don't go further and say, well, what time last night? Nail this down for me. So they don't nail down the last known well time. So the patient said, you say to the patient, how long have you been having this weakness in your left side? Well, it came on after dinner last night. Okay, after dinner last night. Well, some people eat dinner at 3:30 if you're in the gray-haired group. Some people eat dinner at 8:30, right? So there's a pretty wide spread there. You got to drill down deeper and ask the patient to be more precise. And if the patient can't be more precise in general conversation, you can help them with things like, was it after dinner? Yes. What time do you usually have dinner? XYZ o'clock. All right. How long after dinner do you think it came on? So you really have to play investigator, detective, and drill down to get to the best last known well time that you can get to, and not use, at dinner last night after they went to bed. Okay, what time did they go to bed? I don't know. What time does a patient normally go to bed? Were they watching the Tonight Show before they went to sleep and shut off the TV? What were they doing that can help nail this down? So that's another one, is not identifying last known well or symptom onset times, and documenting those separately, independently, and trying to nail down an actual time or a very narrow range of times.
How important is the use of some type of stroke assessment tool? In Massachusetts, we use FastED. Some states, I understand, don't utilize a stroke assessment tool.
Right.
But how important is that in the documentation of a stroke scale objective score?
Again, that's pretty critical, right? The hospital's going to want to see how the patient progressed over time, and that scoring, that scale mechanism, is extremely useful to see if the stroke is progressing or not. And there's a variety of different mechanisms. In Mass, we use FastED. Other states will just use the standard stroke, Boston Stroke Scale, Cincinnati Stroke Scale. There's 16 different stroke scales now or something.
Yeah.
So the flavor of the day for the stroke scale thing. But people have to get used to using that stroke scale and being diligent about scoring it properly, so that they'll have that information for the hospital, when they get there, and that they can later refer back to see if this is progressing or not. So what people often confuse, Kevin, is oftentimes people will say to me, so the auditor will say, didn't do a stroke scale, and they'll score it a 3 or a 4. And so it goes to the MD, and they'll say, yeah, didn't document a stroke score. And so they give it to me as the coordinator, and I go talk to the provider, and the provider says, look, it's right there. In my exam under neuro, I've got, patients got equal, patients ambulates fine, and they give you all the neuro assessment stuff. Well, the neuro assessment is not the same as a stroke scale. And good assessment of stroke patients or stroke type patients is to do both thoroughly. So a good, thorough neuro exam, but then also using your formal stroke scale and quantifying that in whatever manner it asks you to quantify. Like with FastED, there's a numeric value that you attach to each of the components to come up with an overall score. So oftentimes providers will confuse that, and they'll say, I wrote a really good detailed neuro exam, and clearly he's stroking because he's listening to the left and he's got the facial droop and he's got those things. But that doesn't necessarily answer all the questions that are asked in your formal stroke exams. So getting providers to do both is something we have to spend a bit of time on sometimes.
Documentation of the time that the last dose of an anticoagulant.
Yeah.
Is that something that your auditors are seeing as opportunities to be more precise?
Yeah, it is. It's not as big as some of the other stuff we've talked about already. It seems like over the last couple of years, we've seen a lot of, especially new students, get really good at documenting if patients are on thinners in any context, even where it's not necessarily trauma or internal bleeding or a stroke or something that you are worried about it. As part of their normal repertoire in their narrative, they're putting, and patient is not on thinners of any sort, so I don't know if the training institutions, or at least the ones that are in the areas that I'm talking about, are just doing a really great job of doing that, or if people are just kind of doing it on their own. But we're seeing a number of people in different agencies, at least up here in the Northeast, where they're pretty diligent about writing that. So we don't see it too often. We do see it on occasion. When they do their stroke exam and they're asking all the patient all their stroke type questions, that's one that can sometimes be forgotten. So it's a good reminder, but we don't see it as a huge problem generally.
Are there any special or any is there documentation that you want to see specifically related to a stroke patient and moving the stroke patient from the bed to the stretcher?
Yeah, again, that was our last podcast, right? Is how important it is to document how you move the patient from point A to point B. So if the patient's laying in bed and they're having stroke symptoms, you really shouldn't be doing a stand and pivot, right? You should be getting them up. So sometimes providers get a little lackadaisical on that aspect of things. And, the patient says, yeah, I get a little numbness and tingling on my left side, but they don't seem to be, dragging it or being severely neurologically impaired. And so the provider's like, well, he should be good enough to stand. But remember, you're exerting that patient, right, who's maybe in the middle of having a stroke.
Right.
And they're not going to be very stable if they've got some of those stroke-like symptoms, even if they seem minor. So really, these patients you have to treat with a lot of caution, because it doesn't take, remember, if this patient's hypertensive as part of their problem, as part of their stroke presentation, having them move and exert themselves just increases their heart rate and potentially their blood pressure, right? So that's not a good thing for a patient who's already hypertensive. So, be cognizant of it, be careful of it, and these patients you really don't want to be allowed to exert themselves, even minimally.
Yeah. And we talked about that. The podcast will be out in a few weeks, but the stroke patient and the neuro patient, the altered mental status patient, being in that vulnerable group, that we have that duty. We got to move them and we got to control that. Otherwise, they exacerbate their stroke symptoms. How are we doing overall with point of entry protocols, the documentation of notifying that we have a stroke patient and getting the patient to a stroke center?
Yeah, that is one that's kind of agency specific. So some agencies do pretty well with it, but I think the overarching general consensus is, at least with the data that we look at and all the agencies that we work with, is that folks are not routinely giving a stroke alert when they need to. You would think it would happen pretty much all the time. Here in the Northeast, most agencies are stroke agencies that are capable of accepting a patient. So it's not so much about they should have went to facility X instead of facility Y. The issue is they're not giving that notification so the staff is aware of it, so they can clear the CAT scan table and treat this patient with the aggressiveness they need with a potential stroke condition. So and usually the reasoning is the most common reasoning is that the provider wasn't convinced that this was a stroke patient. There was some doubt in their mind because it wasn't the classical presentation.
Okay.
And because they had some doubt, they didn't want to call a stroke and get everybody all worked up if it turns out not to be a stroke. And usually what we have to do is teach them that it's a little bit black and white, right? So go through your protocol. If they meet the criteria and they have the evidence that you see, you call it, but you can still have the discussion with the receiving facility and say, listen, according to my protocol, I got to call this in as a stroke alert. However, I'm not convinced it is, and here's why, right? Speak to them clinically about the medical condition of the patient. And, you can say to them, listen, based on what I'm giving you for a report, I don't know if you want to, but, based on protocol or whatever, I'm not convinced it is a stroke, but technically we're supposed to call it in. So you can kind of work collaboratively with the receiving agency to make that determination if you're in doubt. And oftentimes they'll say, yeah, we'll activate the stroke team or not.
Well, oxygen therapy. One of the when I did my comeback in 2020, one of the
comeback tour.
The comeback tour,
yeah. Lasted what, 6 days? Is that how long the comeback tour lasted?
It was a solid 2 years.
Oh, all right.
Oh yeah. I got hurt before the practical exam, and I was doing that crazy gun class and tore my rotator cuff. Yeah. But this is not about me. But one of the interesting things that I had learned in 2020 is that we're not dumping oxygen into people like it's air, and especially the neuro patient, the brain bleed patient, and the stroke patient. So, how are we critiquing the use of oxygen therapy and the parameters around the use of oxygen therapy with stroke patients? Because it's not about oxygen anymore. Because oxygen causes free radicals. And
that's not a problem we're seeing a lot of, fortunately. On occasion, we'll see the misuse of oxygen, either giving too much for a patient who's already at 99% or 100%, and you've got them on, put them on high flow. So we'll see that once in a while. But generally speaking, we're not seeing it a lot. So I don't see it as a big problem, but in our system, as in a lot of systems, if you see it, you flag it, and you provide that feedback back to the provider so they understand the use of oxygen and how to use it appropriately for these folks. So, but it's not something we see a tremendous amount of. So either the schools are doing a good job training people, or people have gotten that message pretty well through M&M rounds, refreshers, whatever, some other source. But generally speaking, people are pretty good with that one.
So what else are you saying?
Times. Let's talk times, Kevin, because this is one that drives...
Time is brain.
Time is brain, right? So this is one that we tend to screw up providers with because we confuse them. In a lot of agencies and a lot of protocols nowadays, there's some sort of on-scene time. In most cases, it's something like 15 minutes, right? So you get 15 minutes on scene with your stroke patient, and then we want you out and on the way to the hospital. Some agencies have 10 minutes, actually. Some have 20, but most have somewhere around 15 minutes or so.
So this is a medical director specified, or is this in the statewide treatment protocols?
It depends on your protocol, but some protocols will put that in the protocol itself, that the goal is 15 minutes or less, or something along those. Some protocols don't. They just say minimize scene times, don't delay transport. So they use vague language. In those cases, a lot of the medical directors will step in and say, well, here's what because, when we flag them, when it says, don't delay on scene, you read the run report, they're on scene for 18 minutes. Well, is that a delay or is it not a delay? Well, if there's no time parameter to use to measure it, who knows? So we'll oftentimes flag that and say, well, generally accepted is about 15 minutes. That seems a little longer. So let's get it to the medical director and see what he thinks. Let's get him or her to nail this down for us in terms of how they want this agency to deal with that. So the two flip sides you have of this is that the teaching and education around stroke in recent years is not to waste time, minimize on-scene times, and get them to the hospital. Don't screw around on scene is basically it. And the problem is that many providers, and this is a common problem that we see it all the time, is that a lot of providers thinks that means I need to employ a scoop and screw mentality. Right? This is like trauma. Just throw them on the stretcher, extricate them first, don't treat them. Just get them out to the truck, get en route to the hospital, do everything en route to the hospital, and we're thereby doing good with our stroke patients because we had a 30-second on-scene time.
Right.
That's not what is meant by that protocol. They want you to, in most cases, and I very rarely have seen otherwise, the general consensus is they want you to do your baseline ALS procedures, get the line in the patient, maybe shoot the 12 lead depending on the patient. Some protocols are different on that part. Maybe that can be done en route. Some agencies specify that if the patient's seriously ill or whatnot, they want the 12 lead on scene. Others, and if they're reasonably stable, you can do it en route. Others don't specify. So there's all different stuff around the EKG. But usually at least getting your full assessment and getting your baseline IV. If you're going to use oxygen therapy, get it on scene. So do those basic treatments. Check your blood sugar on scene, maybe, especially if there's an altered issue as opposed to just regular stroke symptoms. They might ask that. So there's different variations off of that. But the general consensus is you should be doing at least some baseline therapies and certainly doing a full assessment of the patient, a proper assessment of the patient before scooping them out to the truck and getting going. So that's what providers get confused because the protocol, especially a protocol that's vaguely written, will say something like minimize scene times, and they'll say, well, I did. I got it down to 2 minutes. That's pretty freaking good in my mind, at the absence of treating that patient's airway problem or whatnot. So that can vary a little, and you've got in your system, depending on what your protocol is, and your medical director's dictates are in regard to that. And some of them are very, very nuanced where, some agencies, the medical director has very specific rules and they have extensive rules on each stroke patient. So it depends on whether they're stable versus not stable. And again, there's always a gray area there, right? So not everybody agrees on what the definition of stable is. But they'll say if the patient is stable, you can scoop out to the truck and do most en route. Others will say, nope, get your baseline ALS stuff done anyway, and then take them out. So there is some discrepancy, especially if you have a vague statewide treatment protocol that doesn't give some of those answers. So I think the ideal, the comfort zone seems to be you should be doing at least baseline procedures and treatments on scene, but minimize that to under at least 15 minutes in most, unless your protocol says something different. But in general, most people are going with that 15-minute rule. So don't scoop and screw too quick.
Yeah, you mentioned comorbidities. Well, you mentioned diabetes, which made me think of comorbidities. Are there special circumstances that we need to be aware of in the assessment phase and the treatment phase and the documentation phase? Say, for example, with a patient who may be hypoglycemic but is also exhibiting stroke signs,
Yeah,
symptoms.
yeah, yeah, absolutely. And there's a whole bunch of potential comorbidities, and we'll see the one you just referenced is the most common because we commonly see one of the other common problems. One of the top five items for today's topic is that a lot of providers still aren't getting blood sugars on their stroke patients. And if you've been in EMS for any length of time, I'm sure everybody at one point or another has had a patient who had facial droop, left-sided hemiparesis. They just look strokey all day long, and you got them to the hospital. They did a blood sugar, found it was low. They gave them some sugar, and the patient's stroke symptoms disappeared.
Right.
But it seems so classic in the stroke presentation that the providers bit. They went for the head fake and they bit and they said, "Oh, this is a stroke," and it wasn't. It was hypoglycemia. So part of most protocols, again, now is the requirement that you check a blood sugar, but we still see a large number of providers not doing blood sugars on patients, and and it happens both at the ALS and the BLS level, but we see it a lot at the BLS level as well, where and in that case it's usually a lack of understanding, that it can be, because when you get that, we've all been conditioned to see that hypoglycemic patient as altered mental, but not seeing a facial droop, for example, as the
Right.
presentation for hypoglycemia. So,
Right.
so oftentimes people just miss that, and that's a golden opportunity to talk to people.
What you said five? I think we got five. Are there any added director's cuts that you want to toss in there?
Yeah, we see going back to kind of the delays in patients getting recognized and treated and transported, and we see in two-tiered systems oftentimes where the first in unit won't do a thorough assessment because they're waiting for the second unit to come in to take over. So we'll see that with the PB system, right, where a basic truck shows up. Yeah. They got a patient who's altered and maybe has a facial droop or something, and instead of doing their full stroke assessment and advising the ALS unit coming in that they may have a stroke patient to get everybody geared up for moving. They often will just sit on that patient, not do anything, not treat them, maybe not do a full assessment on them, and say, well, the medics, this is a stroke, so the medics will take care of it, and they wait for the medics to come in. Yeah. We also see that, we do systems in other parts of the country, and in other parts of the country, you have an engine company paramedic working for a fire department, for example, but the transporting agency is a different agency. So another agency comes into town. It might be a private. It might be a municipal another municipal service in town next door that covers a community, a large area over a bunch of smaller area subservices. So even though the paramedic on the engine company sees that patient, they still don't ramp up this could be a stroke. Let me assess it fully to see if it is or is not, and then maybe notify the incoming crew that this is what we might be dealing with. And they may not even start treatments. So those engine companies are usually ALS engine companies, and they can get the IV started while they're waiting for that ambulance to show up, and that'll cut scene times. If your paramedic has to come in, or the transporting medic, I should say, has to come in and start from scratch, then you've wasted that 5, 8, 10 minutes that previous unit was on scene. And we see this sometimes, and this one goes over real well. We'll see this sometimes and I'll use a fire-based service as an example, where you've got an officer in a command vehicle, and he or she gets to the scene before the ambulance does. But that command officer is a paramedic or an EMT, but they're thinking their role is primarily support and to be the officer in charge.
Right, incident
command. They don't think of themselves as the patient care provider. Right. But again, if you can tell that incoming unit this is a potential stroke patient, the crew out of the gate is thinking, all right, we need to move this along. And again, if you've got time to throw them on oxygen, if they need oxygen, make sure you get a thorough assessment so the guys coming in don't have to start from scratch with their question and answer. We'll go collect those medications because we're going to need to take them to the hospital, and all that sort of stuff. Then you can cut that on-scene time dramatically. Most people who complain about the on-scene time criteria are people who are relatively inefficient at providing their patient care. 15 minutes is actually a fair amount of time for a stroke patient, especially an uncomplicated stroke patient, to get there, assess, treat, extricate in most cases. And another point to remember, Kevin, just to finish this up, is that the last bit of this is always documentation.
Yeah.
So you want to make sure you document this fully and thoroughly, and including what people did before you got there, if another service came in and provided some care before you got there, and that sort of thing. Getting those critical times on paper, actual times, as we mentioned, for last known well time and whatnot, are important. How you move the patient from point A to point B, so nobody can accuse you of trying to make a stroke patient stand and pivot.
Yep.
That's why they face planted, is because you did that sort of procedure. So getting all that stuff down, make sure you document this properly and thoroughly goes a long way in allowing agencies to collect the data they need to determine whether stroke patients can get better served by changing protocol or changing care.
Yeah, and to finish this up, and I mean, you can't jump on any of the social media sites without learning how political EMS is getting. And the more political EMS gets, the more evidence, the more objective evidence, objective evidence of right doing that we need to amass as EMTs and paramedics. This is a great example of, and you mentioned it, that engine companies get on scene, offices get on scene, look for something to do there. If there are witnesses there, of the past medical history, present medical history, last known well, don't stand around being an incident commander. Start asking questions, gather that evidence for the oncoming crews, get the patient on oxygen, as you said. Do your EMS stuff to the level of care that you can provide before the ambulance gets there. Anything else, Paul?
No, that's kind of it. Just to finish up, put an exclamation point on that. We just did a call recently, probably a week and a half ago, where there were 3 guys in an engine company, 2 paramedics and an EMT, and they did just this. They showed up. They said, "Oh, little lady's having a stroke," and they kind of stood there and waited for the ALS ambulance to show up, because they thought their job was to be an engine company guy and to help with lifts and carries.
Yeah.
Now the chief doesn't see it that way. He was all bent out of shape with, "Why didn't they treat the patient? What the hell?"
Yeah.
So you can't forget we're this is a team sport, right? We're all in the same team, and the more information that can be obtained from other people, or more help that they can provide for you. If those engine company paramedics had helped with the care, you got all these guys who could start an IV, so you're not stuck with one paramedic on the call having to do everything themselves in a linear format. You can do multiple ALS procedures at once when you have that kind of staffing. So don't forget, brain is muscle. So so we gotta make sure that we're not frying people's brains.
Yeah, time is brain. I don't know about my brain being a muscle, but I get your point. All right. Well, hey, thank you for hanging out with Paul and I. We hope these stroke tune-up tidbits on assessment, treatment, and documentation will help bring your patient care practice to the next level and significantly reduce liability to you as the paramedic, the EMT, and risk to your patients. Godspeed, everyone.
All right, stay safe, everyone. We'll talk to you soon.
On 5.